Hi everyone, my name is Daley and I work at the Ucsf Parkinson Center. I've given a number of talks for the Walnut Creek group, and thanks again for having me. I was sent a series of questions by your group to hopefully provide some answers with, and I'll see what I can do with that. The first question that I'd like to talk to is what does good sleep hygiene look like for a Parkinson's patient? So obviously we know that sleep dysfunction is something that a lot of people with Parkinson's deal with. Insomnia in particular seems to be a real problem. Good sleep hygiene for a person with Parkinson's is the same as good sleep hygiene for anyone who's having trouble with sleep. The main issue that we run into a lot is screens in the bedroom. This can be TV, this can be iPads, this can be phones, and it really needs to be the case that all screens need to be removed from the bedroom. The light that is given off by these sorts of electrical devices is a particular type of light that really messes with your brain's ability to relax, and in fact it does the opposite. It tells your brain to wake up. The worst thing that a person can do if they can't sleep is to grab an iPad and start doing something. One, because you're going to actually start engaging your brain in something other than trying to focus on going to sleep and relaxing, but also that particular light that's given off by the screens is actually sending the opposite sorts of signals to your brain. So if you can't sleep, the thing to do is to get up, get out of bed, go into another room, don't turn all the lights on, have a fairly low light, and get some sort of print material like a newspaper or a magazine and sit and read, hopefully for 15 or 20 minutes, and then go back into bed and try and fall asleep at that point. So you don't want to read anything too engaging. You don't want to take a really exciting novel that you've been reading, but something that is print material that's fairly dry, and something that you can sort of just go over, and it really will just sort of give your brain a chance to lull back into that place where then you can hopefully fall asleep again. The other things are fairly common sense. Try to avoid caffeine, especially near bedtime. No large meals, excessive alcohol consumption, those sorts of things. The next question is, what is the role of exercising in preventing falls or balance issues? Exercise is very important to someone with Parkinson's. Obviously, it's important to all of us, but in particular, people who exercise who have Parkinson's, it does seem like it tends to, in some ways, delay possibly the progression of the illness. But certainly it is great for maintaining balance and warding off those sorts of issues. The best kinds of exercises are ones that are engaging in several levels. That would be things like rock steady boxing, which obviously has probably been the biggest new thing to come out, but things like Tai Chi and yoga. Partially because they do focus specifically on balance and coordination, but also because they are engaging the brain as well in having to remember moves, remember steps, and then having the brain actually communicate those to the body. So those are really the sorts of things that you want to be doing. I would also say that exercise is very important for caregivers, just as a way of relaxation, a way of getting some time to yourself, but also just maintaining good health and focusing on the health of the caregiver. I think too often caregivers will start to neglect their own health, because they are taking care of a loved one. But it is very much a symbiotic relationship in that caregivers who take care of themselves and do better tend to have, people with Parkinson's also have more favorable outcomes. The next question is constipation an effect of Parkinson's disease or of the medications that patients might take, and how might it be treated? So constipation is probably one of the most common issues that people with Parkinson's deal with, and it is very much a symptom of the disease. There might be medications that cause constipation, but everything that I have been led to understand is that it actually is a result of the disease itself. You know, one of the best ways that one can combat constipation is to increase exercise, as we said, which is very important for a person with Parkinson's anyway, and also to increase fluid. People should be drinking enough water, staying well hydrated, avoiding too much sugar, which can also dehydrate a person. And also a couple of things that they talk about with honoring the urge. So making sure that you are in a space that you can, open your bowels when you need to. So if you know that you are someone who tends to go in the morning, then maybe not planning to be on a road trip at a time when there would be no convenient bathrooms to go to at those particular times. They call that honoring the urge. And just knowing that you need to be in a place where you are comfortable and you are able to go when you do feel the need. One of the other ways that you can treat constipation is to take a bulk fiber form or something like a Metamucil, things like that, which just increase the fiber that you have in your body. There are other things such as Miralax, which can also help. People tend to take them fairly regularly, so it isn't necessarily something that you only take when you are constipated, but more so something that you take on a regular basis so as to avoid constipation and continue to have regular bowel movements. There's also something they call a prune juice cocktail, which can be used. And it is easily made using applesauce, bran fiber, and prune juice. And it's mixed together. Usually you keep it refrigerated, and a person will take a couple of tablespoons of that a day. And basically that also is just increasing the fiber intake. But some people have said that it does actually make quite a bit of difference, particularly when taken regularly. These next two questions are sort of together, so I think I will read both of them and try to answer them. How can care partners manage themselves during the COVID-19 virus and their PD partner? And then what are thoughts about respite care or backup care for the care partner who's feeling emotionally stressed? Are there best practices? So certainly, we are all sort of learning how to live in a new reality right now with the COVID-19 virus pandemic. And I think that it has brought our levels of anxiety for everyone up quite a bit. And, people react differently to anxiety and stress. The important thing to remember with all of this, and especially for caregivers, is just making sure that you are taking time for yourself and making sure to take good care of yourself, finding time each day to do something that brings you some joy or satisfies some need that you have. We can't always be focused on everything else, much like I think if we sat and just watched the news cycle continuously, we would all fry out, pretty quickly. We just aren't supposed to be taking in this constant, sources of information over and over again. So it really is the case of just making sure to go for a walk once a day, or read a good book, or make sure that you are reaching out to other people. I think the best practices really to remember is that we are social people, creatures by nature, and that we need people. And that's been probably one of the most difficult things about this particular crisis, is that it really has alienated us all, and that we are all separated and isolated. And, it can really, really affect us negatively, not being able to connect with people. And the hardest thing to be able to talk to someone, but not to be able to sit next to them, to constantly be thinking about, am I remaining at a safe distance from someone, rather than this is my best friend and I would love to sit on a couch and talk to them at length. So I think best practices are just to make sure that you're finding ways to decrease your stress and anxiety during this very stressful time, however that fits for you. Things like yoga, things like meditation, things like mindfulness exercises, of which the Parkinson's Foundation actually has a number of them listed, and I also can provide those links to your group. They provide ways that people can do those things and engage with exercises, but also engage with other people. Zoom has been one of those things that has sort of come out of this crisis and shown that we can interact with people in a remote digital sort of way, but still remain contacted. And I think that it is not a great substitute for actual interaction with people, but certainly just seeing other people can be very comforting. And making sure that you are connecting with the people and doing the things that you need to do to keep yourself in a good state of mind. And along with that, just remembering that no one really can do all of this stuff alone. And as far as having backup plans or respite care, I think is a great conversation to have. It's something that you can bring up with the neurologist as well. But making sure that you have someone in mind if there was a crisis or if there was some sort of acute problem that needed to be dealt with, that there's someone that you can always contact in a time of an emergency, and making sure that they are comfortable with being that person. But I think it also is just, a lot of what we talk about is just making sure that you have some plan in place and that both of you are aware of it, both the patient and the caregiver. Whether that means having the person's phone number, written down on a piece of paper and put on the refrigerator with emergency contact written over it, something along those lines. But everyone should have some sort of backup plan. I think that you never want to be making plans in the midst of a crisis. So having that already established is good. And coupled with that is, again, I know I've said it a couple of times, but making sure that the caregiver is taking time to address any concerns on their own health, making sure that they're keeping doctor's appointments for their own, illnesses or otherwise, as well as just, that they are taking time for themselves each day. Are there any statistics showing if COVID-19 has had an impact on the Parkinson's community? This isn't something that I have heard. We have talked for several years, obviously, about how, in particular, pneumonia and aspiration pneumonia is a real danger with the Parkinson's community. Now, COVID is providing a sort of a different type of pneumonia, but it is still a respiratory illness. I think more than anything, this is probably affecting the anxiety levels and the depression levels of people with Parkinson's who might also be prone to those sorts of problems to begin with, and the isolation as well. I think also when people with Parkinson's are told that they need to move around and they need to exercise and they need to get out, and then also at the same time being told that they need to shelter in place, can be really tough from an emotional point of view. But also, some might take the opportunity to say, well, I can't exercise, therefore I'm not going to leave my house. I think that we know the benefits of exercise, and in particular, we really do know the benefits of exercise for people with Parkinson's. And in a safe way, those need to be stressed and continued, because it really is the case that exercise can really help people. Does UCSF take brain donations for research? It's a complex question. So there is a place at UCSF called the Memory and Aging Center, or the MAC. And if a person is a member of that, then I believe brain donation is possible. However, you have to either be a patient there or you have to be in one of their research studies. But and the MAC generally deals with people who have atypical forms of Parkinsonism. So the garden variety idiopathic Parkinson's disease patient would not be seen at the MAC. There is a program based out of Southern California, which I can provide the information for to your group, which seems to be more open to everyone. There also is a group called the Brain Support Network, which is based out of Menlo Park. They also do take brain donations. However, it is sort of an application process, and you would need to reach out to them, and I can provide the information for them as well. The next question is strategies for caregiver in handling the cognitive decline of a person with Parkinson's disease. The main thing I would stress is to keep the neurologist involved if a person starts to show some sort of cognitive impairment. The neurologist needs to know when these things are happening, how they are happening, what the caregiver is noticing, and then they can sort of respond to those things. Probably the first thing that would happen would be that they would take a MoCA test, which is just sort of a short form test gauging cognitive impairment. So discussing strategies with the neurologist would also be very important. Some of the things that you might also consider, easy things like writing permanent notes, as we mentioned before, writing an emergency contact, but also notes that can be posted around the house that just sort of help the person to remind them, if they're not supposed to be turning on the oven, something along those lines, that there is a note that's posted on the oven that says, do not use, or things like that. Also, putting in night lights around the house would be good, especially for nighttime, for bathroom visits, things like that, and just providing a clear pathway to and from the bathroom. Cognitive problems in people with Parkinson's tend to be in what they call the executive functions. So this makes it difficult for people to do things like multitasking. So one way that a caregiver can help is not to overburden a person with Parkinson's with too many choices. So, not providing 5 different examples or 5 different options, but just giving 2. And also, when having them do something, not to also be trying to get 3 other things done at the same time. So that sort of juggling of tasks becomes more difficult for people with Parkinson's, especially if cognitive decline starts to be a problem. So this is part 2. The next question is how to address the person with PD whose thought process is negative and who is assuming and saying things which are not correct. I'm not quite sure about this question, but I will attempt to answer what I think it's asking. One of the main things is to make sure that you're speaking with the neurologist about these issues, and chances are that the neurologist will probably screen for things like depression, as well as possibly some sort of cognitive impairment. But there is something actually that's well documented within Parkinson's patients of a certain degree of apathy, where they just, people can't be bothered. People can't sort of motivate themselves and don't really particularly care about anything, really. There's just a certain degree of apathy about sort of everything. And the problem is this is really hard to treat. It used to be the case that the neurologists thought that this was, just an aspect of depression. But then in treating the depression went away, but the apathy remained. So it's really something that is, quite perplexing for obviously the clinicians to deal with, and also for the patient and the caregiver as well. So I would say that, it really is the case that communication is important, both with the patient as well as with the patient's treating neurologist, and that there is no sort of secret weapon or silver bullet that can be used for people whose thought processes tend to skew negative. But certainly, any underlying causes that can be treated, such as a depression or anxiety, certainly should be explored. Now, the other part of that question is assuming or saying things which are not correct. So if that is the case, and that the person is saying things which are not true or is showing some signs of possibly a dementia. Certainly, that's also something that should be brought, to the knowledge of the neurologist very quickly, so that those sorts of things can be addressed. But as far as if it is the case that the person is just always assuming the worst or something along those lines, then it's possible that a screen for depression might actually be a good first step. There is something called a pseudo-dementia, which actually can form in a person who has untreated depression, and it looks very much like dementia. However, once treated, the depression goes away, the dementia can actually go away as well. The next question is, what guidelines or steps a caregiver can follow in setting up a daily or weekly routine for a person with Parkinson's? The main thing to remember here is that communication with a lot of these things is going to be key. So making sure that the caregiver and the patient are really having a very open dialogue about what it is maybe that the caregiver is hoping that the patient might do and what the patient feels comfortable with. This isn't always going to be a one-time discussion. This is going to be sort of a developing discussion. But I think that developing a routine is very important. One of the things that we know for sure about people with Parkinson's and medication is that they do need to take their medication at regular intervals. And that's something that if a patient has trouble remembering, the use of a medication reminder, like maybe with smartphones, a timer or an alarm that goes off 3 times a day, can be really effective. And as far as the development of a weekly or a daily routine, making sure to stress that activity is very important, which obviously I have brought up several times already, that exercise, but also that social activity is really important, and engaging with other people. And that needs to be built into the routine of a person with Parkinson's on sort of a daily and or weekly basis as well. We obviously are in strange times right now where activity and engagement is not something that's really easy for us to do because we are all sheltering and self-isolating. But the hope is that this crisis is going to pass and we can get back to some semblance of a normal life. And certainly, social activity needs to be a part of that. People who isolate really don't tend to do as well as people who interact, who have regular interactions with others and keep engaged. Now, the flip side to that I would say is caregivers and patients need to also be mindful of not overloading schedules, and that activity is a good thing, but like all things, it should be done in moderation. It should be done at the comfort level of the person. It needs to be done in a safe way so that it isn't, making a person either have to drive long distances or go into positions or places where they don't feel comfortable. So I think that is just the one thing also to keep in mind is that, engagement and activity is an important thing, but it isn't the case that you have to fill every single minute of every single day. The next question, are there any new research or treatments for Parkinson's disease that look promising? So there's always research being done in Parkinson's, and we have several studies that are either opening soon or currently open. And there are some new medication treatments that are coming out as well. So I'm not a physician, so I'm probably not going to talk too much about that. I will say that there are 2 drugs that have come out recently. One is called Umbria, which is an inhalable form of levodopa. It is mostly used as an adjunct therapy for people who have off times. It is not supposed to be in place of regular levodopa therapy, so the Cinemet, but something that people can use when they have off times during the day. If that was something that you were interested in talking to the neurologist about, then certainly I know that it is available now. The other drug is called Neurologist, which also has to do with decreasing the off time of people, and I believe in some ways boosts the effectiveness of the dopaminergic therapy that the person would be already on, so the regular Cinemet. So those are the two new drugs that I have heard about recently. As far as research studies, the one that I would probably say most people might be interested in is there is a study called the Topaz study, which is looking at fractures in people with Parkinson's and trying to decrease the risk of fractures, in particular hip fractures, with people through a one-time shot of a drug that is supposed to strengthen the bones and hopefully ward off possible fractures. So Topaz, T-O-P-A-Z. The nice thing about this study is that it actually is one that if you signed up for, the nurse actually comes to your house to give the injection, so there are no study visits, and it is a one-time injection, and then you are tracked, I believe, over the next couple of years. They are trying to enroll, I believe, 3,500 people into this particular study, so that would be probably the largest Parkinson's disease study of record, and certainly is widely available, and I can provide the information for that to your group as well. But that is probably the one that I know of right now that is open and recruiting, and also is obviously very easy to be involved with because the fact that they actually do home visits for the study itself. The next question is address research for Parkinson's-like syndrome, such as Parkinson's multiple system atrophy. Progress of that research is. So MSA is one of those atypical forms of Parkinsonism that I mentioned before. And what usually happens with MSA is that there are signs of Parkinsonism, but there are also additional findings, and in particular things having to do with the autonomic nervous system. So things like dizziness, lightheadedness, low blood pressure dropping when standing, and other things related to that, difficulty in your body sort of regulating itself. Research into that I don't know much about. However, as I mentioned, the Memory and Aging Center at Ucsf is the place where a lot of people with these atypical forms of Parkinsonism are seen, and they certainly have a very robust research wing. And I believe anyone who is interested in being involved or finding out more about research into these sort of atypical forms of Parkinsonism, the Memory and Aging Center would be the place to contact. And I'm happy to provide that contact information. So the last question here is suggestions regarding intimacy for caregiver and a person with Parkinson's disease. So, this is a question that does get asked a lot, and obviously it can be a big issue. The thing about Parkinson's disease is that it can affect, obviously, the way people move, the way people communicate, the way people interact, the way people feel about themselves. And all these things, affect the feelings of intimacy and the feelings of closeness that people can have. One of as I've said before, the real key is communication. There needs to be an open line, an honest open line of communication between the caregiver and the patient. And there are plenty of strategies for building intimacy or rebuilding intimacy. And most of it just comes down to opening that line of conversation between two people. It is usually something that's very hard to start talking about, but the more that it is talked about, the easier that it becomes. Now, there are a couple of things in particular, making sure to talk to the neurologist if there are, or your primary care provider about changes in sexual function, because there are some physical things that can be going on, in particular if, say, a person or a man is experiencing erectile dysfunction, making sure that they're having regular prostate checks and that there isn't some sort of issue related to that. Checking with medications to see if maybe one of them is a side effect, that is a side effect of the medication. So the other thing is that anxiety and depression can both really affect people's sexual functions. And so making sure that any sort of underlying causes like that are being addressed. Another thing I think that's really important to remember when talking about sexual intimacy is, allowing a certain sense of flexibility. I think that too often when we talk about sexual involvement, we're talking about sort of goal-oriented intercourse, and that would be, the achievement of an orgasm being the goal. Now, if you bring into the fact, some of these sort of sexual dysfunctions that someone might be experiencing, if they remain committed to a goal-oriented experience, then the chances of being let down really do go up. So a lot of therapists will talk about adjusting to a more pleasure-based or pleasure-oriented sort of sexual involvement. And that can include things, what they call outer course, so things that are not actual penetrative intercourse, but more pleasure-oriented outer course. So using the hands, giving sensual massages, things along those lines. And the base of all that is that you really are trying to build more intimacy between the two people as well. The hope being that as you bring more pleasure to one another, that you hopefully are also really increasing the intimacy between two people. I think I would also like to underscore as well that seeking counseling, and that there are things like couples therapy that people certainly can seek out, and that there are actually sex counselors as well. So counselors that are specifically trained to help couples who may be dealing with sexual function or issues related to it. And so certainly if it is something that both parties are comfortable with, that bringing a therapist or a counselor in as sort of a consultant can be an important thing as well. And I know that there are plenty of couples therapists that are well versed and trained to deal with those sorts of issues. When we talk about intimacy as a whole, so just as bringing the connection between two people and making that stronger, that there are very broad things that people can do as well. The main thing being, again, communication is very important, but also making sure that you are taking your time, that you are being involved in the other person, that you are showing an appreciation and a care and a love for the other person, and making sure that it is reciprocal. And that there is no rush for any of these things, that it really is that you are building something. It isn't the case that sort of, you have a good talk and then everything is done, but it really is sort of a journey that both of you are going to be on. And through that journey and through those communications, though they may be difficult at times, you really are also building intimacy at the same time. And the last thing that I'll say about intimacy is, that they talk about there actually being 4 different sort of aspects to it. So that there is couple time, which is just spending quality time together, and that built intimacy, that has nothing to do with sort of anything in the sexual realm, but it's just spending time doing things together and enjoying each other's company. And then a part of that is actually also that taking personal time for oneself and making sure that you are doing things that make yourself happy, because the more pleased you are and the more things that you do that gratify yourself, the more likely you are to be better involved in building intimacy with another person. And then that there are intimate times that you can have that are that can be emotional, that can be physical, but it's things like going on date nights or taking your partner to a restaurant that you haven't been to for a long time. Those sorts of things that have an emotional charged component to them, and really kind of show that you do care for the other person and that you are wanting to build more intimacy. And then obviously finally then sort of having sexual experiences, which would be more focused obviously in the pleasure that we talked about, and trying to provide and receive pleasure from your partner in whatever sense that makes both of you feel the most comfortable and also the most loved and building that intimacy. Well, I want to thank you for the opportunity to answer some of these questions. I'm happy to follow up on any of them that there are additional questions on, but I just want to say that the UCSF Parkinson Center is available to everyone, and my contact information hopefully will be provided along with this video, and please feel free to shoot me an email or give me a call, and I'd be happy to talk to you further. I also hope that someday soon that I can return and start talking with some of the groups at the Mount Diablo meetings face to face. And I hope you're all staying healthy. Wash your hands, and hopefully we will be through this sooner rather than later. Take care.